Good morning. Thank you, Catherine, and welcome again to our third annual Maryland State of Reform. We are very proud to have you here today and join us for this conversation. There are lots of things to be proud of in Maryland. I'm a proud Marylander. I've been living here for 50 plus years. Proud graduate of the University of Maryland. I've worked in the Maryland landscape since the early 2000s, and just proud to have contributed to improving healthcare for Marylanders over the last 30 years. But I have not been as busy as these two. And what they're going to talk about today is where we've been this last year, where we're going in the next, I guess, up to 10 years. And I think you're really going to be really interested in what they have to say about their vision for the Maryland Medicaid landscape as well as the Maryland behavioral health landscape. So the way that this is going to work, I'm going to introduce them in just one moment. They each have some prepared remarks. I'll ask them some questions, and we'll have some time at the end for you to ask them some questions. So our first speaker today is Ryan Moran. He is the Deputy Secretary for Healthcare Finance and the State Medicaid Director. He has been serving the 1.7 million people on Medicaid for the last 16 months. He's almost made it to that 18-month mark. He has rolled up his sleeve. He's had to deal with unwinding and a bunch of other things, and wait till you hear what he has to say. He has previously been the CEO of Whitman Walker Clinic in Washington, D.C. He is a proud graduate of Johns Hopkins Bloomberg School of Public Medicine, and he has a master's degree in Health Services Administration from Xavier University. On my left is Alyssa Lord. She is the Deputy Secretary for Behavioral Health here in Maryland. Lord brings more than 20 years of experience. I happen to know she's a good friend of a colleague of mine working in New York City for more than 20 years, Vice President of Healthcare Strategy of Large Housing, Healthcare, and Workforce Development for nonprofits, where she was setting the vision for healthcare, behavioral healthcare, substance use services, homeless services in unstably housed New Yorkers. That's a huge job. She's also responsible for establishing university community partnerships in West Philadelphia, and she earned her master's degree from NYU and the London School of Economics. So very proud to be here on the stage with them. So first up, Ryan, you want to give your remarks? Thank you.
Good morning. Some of you have heard this before. I asked for this lectern because I'm a preacher's kid, so I am most comfortable in the pulpit, if you will. But good morning, Robin. Thank you so much. I am elated to be here, and I also want to thank Alyssa as my colleague and partner in crime at the department for sharing this opportunity together. Today is really a State of the Union, if you will, or a State of the State on Maryland Medicaid. And also, I also want to frame this particular moment as we think about it. Of course, I'm going to address what has really been an unprecedented year for the Medicaid program with unwinding and redeterminations. But I'm also going to give you some insight about what lies ahead for the program as if we didn't have anything else to do in terms of the new federal rules that are on the horizon that really will chart all state Medicaid agencies over the course of now up till 2030. So if I can do this right. Good, I got it right. I also want to set the context in terms of the Medicaid program, in terms of the administration's priorities under Governor Moore and Secretary Herrera-Scott. I'll talk a little bit about what we actually authored to provide at State of Reform Conference last year about the vision and the goals of the Medicaid program moving forward. And then again, I'll touch on the federal landscape, sort of bringing unwinding together with the new federal rules that will keep us busy to 2030, if you will. You really can't think about Medicaid in terms of the vision of this administration without thinking of it in the terms of an anti-poverty program. Specifically, Governor Moore has set out priorities that is being committed to ending childhood poverty. And one way to do that as part of the goals of the administration is to ensuring that we are focused on the well-being of Marylanders, and we're creating a world-class health system that makes concerted efforts to achieve health equity and excellence in our system. And you can't think about attaining those goals without thinking about Medicaid as a vehicle and a tool to achieve what you hope to accomplish with those particular goals that are laid out. It's well documented, as you'll see here in the literature, in terms of Medicaid being a tool for anti-poverty. Studies and the stats that you see have shown that reflection of health care benefits reduce poverty for kids and their families. I often refer to Medicaid in legislative briefings and hearing as the most important safeguard for Marylanders to achieve their full health status, and that is certainly true for the people that we serve. Additional context, 40% of all the state's births are individuals of Medicaid participants, 700,000 kids, 3 in 8 in the state, 1 in 3 Marylanders living with a disability, and more than 2/3 of people of color. And if Medicaid is, yes, that essential tool to support those particular goals, you can't get there without having coverage for individuals in the first place. And that is why our administration made the work of redeterminations on unwinding our top priority. I see a lot of familiar faces in the audience who come with me with a number of different requests and asks. Over the course of the last year, people have asked, what's the top priority? The number one thing, if you can only name one thing in terms of the Medicaid program, and it was, of course, redeterminations. We have been laser focused on this as an administration, and I think from what you can see on the screen that our results speak for themselves. I also want to publicly thank our managed care organizations. I see a number of them in the audience, Kaiser, Aetna, others may be here, I can't see from the lights. The Managed Care Association for working with us on the important messaging of the signature campaign of Medicaid Check-In. I want to thank provider associations who might be in the room, community-based organizations that helped us leverage to get the message out. And I also want to thank my colleague in crime, and Michelle Eberly from the Exchange, who just did an extraordinary work in partnership with us as well. Maryland has been recognized as a national leader in this particular space, where we were in the top 5, HHS urging all governors and their administrations to take advantage of federal flexibilities to help people keep their coverage. Just for some context, in 2022, legislation passed express lane eligibility that links SNAP and Medicaid eligibility at the time of renewal. We included that federal waiver as one of the options that you could use as part of this process from CMS while we waited on our full waiver authority approval for that to happen in the future. And that has allowed 226,000 Marylanders to retain their coverage by linking that work. We're ranked in the top 10 states in terms of coverage retention. I'm not competitive. I looked this morning, we were number 8. In terms of more than 70% of Marylanders who have gone through the process have ensured that their coverage is extended. We took important steps, along with Michelle, to ensure that we improved our automatic enrollment rates, increasing from about 45 to 50% in COVID to 67% in the months of March and April. So important in terms of the lens of anti-poverty as well. That means that kids and families never touch a piece of paperwork to retain their coverage. And over 100,000 individuals through automatic enrollment pathways were referred to the exchange, and more than almost 40,000 by now have signed up to enroll in a QHP. The present moment, if you look at this, and there was a lot of folks opining on the estimates that would be made in terms of nationally the number of Medicaid members that would retain coverage and where state Medicaid programs would be after this particular year. If you look at our enrollment back to COVID, pre-COVID, we were about 1.4. We grew because of continuous eligibility about 1.8. And enrollment as of today stands at 1.681 million. That is a significant increase from a pre-COVID baseline. And I think it's important to note, it's not as if more people are necessarily eligible than they were in 2019 or 2020 when we started the process, But we believe our efforts to focus in on automatic enrollment and the work that we have done with some of the waiver flexibilities, some of which will remain in place, we are ensuring that people that are eligible are remaining on the rolls. I also would be remiss if I didn't thank one of the sponsors that's here, the Hilltop Institute. I think I saw Alice walk in the room, Alice Middleton. They have just done an extraordinary job as a partner in data analysis. We led also the country in producing our results by race and ethnicity and other demographic categories. That's publicly posted on our line, and we have a commitment of transparency to continue to produce those enrollment futures in the future. I'm going to speed up. Vision of Medicaid. So 1 year ago, we authored sort of a roadmap here at State of Reform, a vision and aspiration of who we wanted to be and what the Medicaid program wanted to establish. And we've been working on ingraining this vision across all the 700 staff across Medicaid. The first in innovation and access, and I'll just sort of highlight a couple of things that we're working on. We are proud of the governor and the secretary of an investment in the next fiscal year to make a housing case management services statewide after a successful pilot in 4 jurisdictions, thinking about the intersections of social determinants of health, particularly housing as one of the key drivers. With continuous eligibility for kids, kids stay covered for a full 12 months regardless of their change in income. While that was a federal requirement, we were well ahead of federal timelines to do that. We're working on pathways of Medicaid coverage, pre-release up to 90 days of services for individuals from carceral settings, and we're partnering with the Department of Juvenile Services on services pre-release for kids as well. In the equity space, in this past fiscal year, we had a successful launch of the Trans Health Equity Act, recognized as leader in gender-affirming care. Happy Pride indeed. Manat has, yes, thanks, Robin. We had an article from Manat which sort of features how the department did a collaborative work with Trans Maryland to really bring in the voices of individuals and participants receiving the program. And when you do that, your outcomes are, of course, better. Healthy Babies Equity Act, coverage for pregnant individuals, but for immigration status. We've seen 10,000 individuals through the course of the year come into that program. We're requiring and working collaboratively with our MCOs to achieve health equity accreditation in the next year, setting standards around 7 to 9 key principles through NCQA. Total cost of care alignment, Medicaid must be a central part of the component of AHEAD under the Secretary's leadership. We're building and designing an investment in a primary care model. We're also working with our MCOs on increasing accountability for quality outcomes through performance improvement and other incentive programs. And we're taking a hard look at the long-term services and support continuum, everything from pre-Medicaid to home and community-based services to institutional services. And there's a huge emphasis of that in the federal rules as well. I'll defer most of my comments on behavioral health to my colleague and all the collaboration that we're doing in that space, which is really, there's so much good work happening there. However, if you were to ask me in the next year, what is the number one thing you would say as the top priority for the next year, redeterminations, of course, was last year, I would say January 1, 2025, our behavioral health providers deserve that authorizations are processed and claims are processed. And the transition of Carolyn could not be more of a top priority for our team and administration. Operational excellence, which is what I refer to as the three-prong of people, systems, and process. I refer to this bucket as getting the basics right for the agency, investing the time, effort, and resources that you need to leave the Medicaid administration better off than where we found it, and navigating what is a critical moment in public health of post-pandemic response and post-pandemic build back in the agency. I joke sometimes, I don't think people come to Medicaid director seats to say, wow, I really want to update information technology systems, or I really, really want to focus in on the people in the agency. I do. I actually love that part of the work because it is foundational to the policy goals that we have and that our administration shares, but we must be focused in on organizational leadership and people development across the agency. How do we do that? We've taken steps to reduce our vacancy rate. We're taking a look at automating processes. We're clearing backlogs of any kind. We've gone, as examples, 19 months of a backlog in the long-term care provider relief unit down to 9 months, and we're slashing that even further as we move forward into the future. And then we continue to navigate the post-implications of the security incident that happened in the department in 2021 and 2022 in terms of our basic operating procedures. And if that didn't keep us busy enough, it's important to outline, and I'm not going to go into these on details because there's a lot of organizations that are writing their own opinions and their own reflections about the summary of these federal rules. But on April the 22nd, there were some significant rules that dropped from our federal partners at CMS. The overall goals of these particular rules, they're in the home and community-based services space or the managed care space, but they really look to strengthen access and the quality of care, addresses things like rate transparency, minimum wait times, quality star ratings, enrollment and eligibility processes, and bringing the participant voice closer to the process. You'll see here that this map shows, and you can find it online through the National Association of Medicaid Directors, but this shows the time frame of which each one of these individual rules must be implemented from 2024 all the way to 2030. And further, in partnership with a number of you in the room, we worked on some significant pieces of legislation in the past session. We're producing almost about 50 different reports and studies that cover a wide range of coverage and services for the legislature to consider in the future, some of which I'm sure you'll hear about at some of the sessions today. Everything from a community health worker reimbursement study, coverage of anti-obesity drugs, dental expansion to include dentures, coverage of orthoses, the expansion of our employed individuals with disabilities program to ensure less restrictive eligibility requirements, biomarker testing, increased rates for certain specialties, the list goes on. And I will close just by saying that I thank you all in the room for your partnership in this work together. It is a tremendous honor and a privilege to do this work. And I invite you and I deplore you all as your Medicaid agency to invite you into this space to ensure that let's keep going and let's keep going together. Thank you.
Good morning. Y'all can do better than that. I know it's a Friday, but good morning. Thank you. So really, it is my honor and privilege to be here this morning. Alyssa Lord, I joined the department maybe about 10 months ago, as you heard, moving from the New York area. And I will say, I feel more like a Marylander in 10 months than I ever felt in my 9 years living in the New Jersey suburbs. Don't tell my husband that. But I am grateful for the very warm welcome that I have received since moving to Maryland. Deputy Secretary Moran, thank you for your ongoing partnership and collaboration. I'd also like to thank State of Reform and HMA for having us here today. There's a lot of ground that we have to cover in the state of Maryland when it comes to providing optimal behavioral health services, and I think we're getting there. And I want to thank all of you in the room and those of you that are even not in the room. It is very cliche, but it certainly takes a village. And with that, let's talk a little bit about the village that we're building. And let's see if I can figure this out. Okay, got it. All right, so we're going to talk a little bit today around what are we doing as it pertains to the behavioral health continuum of care, take a look at how we're understanding and ingesting our data by mapping the white space of where services do and do not exist. And what are our priorities? What are we focusing on over the next year or so? I know Robin said 10 years. Robin, I'm just trying to take it day by day. So I appreciate the 10-year notion, but we'll get there. Hopefully what we're building are the foundations to 10 years of success. And then we had a very robust legislative session. I see some familiar faces, thanks to those of you that showed up to provide support for the tremendous work that across the administration that we're trying to do. And as Deputy Secretary Moran mentioned, you know, this is really a pivotal time in which we have a governor, a lieutenant governor, and a secretary who have made it very clear that behavioral health and the health care of Marylanders is a top priority. So we, with intention, are looking to execute on that. So when we see this slide, in all honesty, this is really us going back to basics. The behavioral health continuum of care is not necessarily an unknown concept. It's figuring out how you map the who, what, where, why, and how people are accessing services and care. And so we did just that. And if you think about this like a thermometer, it's looking at from sort of the least to most restrictive settings of care with our ultimate goal of treatment and recovery. The other thing, and I know you hear this all the time, is that we want a seamless model of a system delivery of care. And that's not always the case, right? We have an understanding, a deep understanding of, depending upon the color of your skin or the neighborhood you live in, how you may access services is certainly not equitable. And so we want to make sure that as we're building out this continuum, we are really thinking through the implications of how we utilize data, how are we building a robust workforce, and that's all through the lens of health equity. And I know you heard Deputy Secretary Moran talk about some of those initiatives as well through the work of Medicaid. But what we've done is we've mapped prevention promotion, primary behavioral health and early intervention, and that's where we're doing a lot of our work around children, adolescents, and families. And I want to root on the notion of families very intentionally. When I joined the department, everything that I saw was about children and youth. I said, what are we doing for families, right? And if we're not serving the family, or if a child is in crisis, most likely the family is in crisis. So we need to be really thoughtful about how we're building models of care that have family and family very broadly defined. Urgent and acute care is a new pillar for us, and it really comprises the work that we're doing around 988 mobile crisis and crisis stabilization. And last but certainly not least is treatment and recovery. And what you see here is sort of a deeper dive of how we are mapping our service delivery. This is a point in time. It is a living, breathing document. It is not meant to be static, but it's how we start to think about mapping out the services that we're providing across the lifespan. And what you will see here are some of the things that are funded by Medicaid, some of the things that, Ryan, we'd like to get funded by Medicaid. He knows, because he gets a weekly email from me of like, what can we do? And then also some of this is really reflective of the innovation that's coming out of our local jurisdictions, of the needs that they're identifying and how they're building program, and then coming to me saying, how do we pay for this? And then me going to Ryan saying, how do we pay for this? And so the other piece that's important about this is that this framework is something that we are working across our sister agencies. You heard about our partnership with DJS. We also have a partnership with DHS. And then what I'll talk about in a second is how we are working with the Maryland Consortium on community supports. And I don't know if Mark Luckner or his team is in the room, but just a shout out to them for their tremendous partnership. As many of you know, this was added to House Bill 1300 in 2020 as part of Maryland's blueprint. And so it was very intentional around how do we make sure that we are getting school-based services and how are they provided. And so this has been an ongoing labor of love between the department and the consortium of how do we think about making sure that there's not a duplication of efforts and that we're marrying the work that we want to provide for our children, adolescents, and families. And with that being said, you'll see, we shared with them the framework, and what they've done as they were doing their review process, along with all their stakeholders, is they started to think about how do we marry these concepts of the behavioral health continuum of care, and how do we prioritize funding for our jurisdictions. And so this is just an example of how our partnership with the consortium is really elevating the overall mission and vision of what we're seeking to accomplish across the state. It is very much the notion of all hands on deck. And I'll give you an example in just a second around the work that's being done in Baltimore City. So Baltimore City received 11 grants. And what they did is they mapped this against the various different pillars. So what you see here on the promotion side is around mental health awareness, parent education, social emotional learning for universal prevention, after-school programs for selective prevention, expert indicated prevention, and on the outpatient care side, school-based services, which we know is something that is near and dear to many of us, and it's on its way. So again, what we wanted just to be able to share is that we're not doing this in a silo. We can't begin to address the needs of our communities by working in disparate ways in disparate places. And so we're thankful for the ongoing partnership that we receive from our sister agencies. I want to talk for a minute about how we're really trying to understand where services are being delivered. And what we've been doing is taking an extensive review of our public behavioral health system data. And then it's nothing fancy, but we're mapping it. And it is inclusive of feedback that we get from our community partners. So you see a thank you. It comes from our local behavioral health authorities. It comes from our community-based providers. It comes from our providers as a whole. And then what we've done is we've broken it down by what is the different funding source so that we can understand what our total investment is. The other piece is that we need to start tying our investment to outcomes. So that is what is on tap for next. And again, this is small, and actually, you can access this on our website. We've actually put this out for public review. And what you see along, we have our jurisdictions listed along the side, and this is just a snapshot, so it's not inclusive of all the services. And then across the top, what are the various different services that are offered in the community, and then what is the various different funding source. And then what you see are the white spaces. And this is what we're trying to do, is to try and map the data that we're getting from the public behavioral health system with our white space and figure out, is this a service that we need in the community? Is it a regional approach? What are the different types of strategies that we need to think about ensuring that we're filling some of this white space accordingly? And with that, it gets us to some of our priorities that we're focusing on. A lot of work is being done around peers. We are over 300 peers. I think it's 333 that are funded by the state, and that our investment we're anticipating going into the next fiscal year is about $29 million in peers. It was $26 million this past fiscal year. A lot of work that's being done around suicide prevention. We actually just took a look at some of our 988 data, and we saw about 4.3% of calls were from individuals who had a plan for suicide. And about 2% of those, all 4.3%, thankfully, for the most part, I think there was only one that I was made aware of where the plan was acted on, unfortunately. But we've been able to make sure that people have been able to get access to care. Problem gambling. We are seeing rapid increases, particularly in school-age youth and college-age youth, for problem gambling and issues around problem gambling. So we are actively partnering with the Center for Excellence on Problem Gambling to figure out what are new ways and new strategies that we need to infiltrate the community to get them the access and care that they need. Veterans. This is something that will remain a top priority for us. And I will tell you, most recently, we actually had one of our own team members who is a veteran go through some pretty difficult times. And so it hits very close to home. And so we want to make sure that we're continuing to build that robust network of care. On the primary behavioral health side, a lot of work in partnership with Medicaid around early and periodic screening and treatment for our youth, our integration with primary care and pediatrics and behavioral health to make sure that we're identifying services, and then we're going to be continuing our work around Project ECHO of bringing together the provider community. You heard me mention mobile crisis and crisis stabilization. So we recently announced $13.5 million in investments in this past fiscal year as part of the governor's 107.5. We're going to be continuing to expand that work going into fiscal year 25. And then you've heard the work that Ryan mentioned around our justice-involved services. Treatment and recovery, we are focusing a lot on housing and making sure that we have pathways to sustainable housing for individuals in recovery, and making sure that we're creating discharge plans that are reflective of the need for permanent supportive housing. And then MAT and MOUD, right? We need to make sure that we're continuing to provide access to those services. And then I'm sure you all, I'd be remiss if I didn't mention, I'm sure you all have seen the New York Times Baltimore Banner article. And so we do know that our older adults are facing a disproportionate, unfavorable outcome. And so there's a lot of work that our team is focusing on there. And then also regulations. 1063, lots of feelings, very big feelings about 1063. So we're revisiting them, and I was just talking with a colleague out in the audience that during the month of July, we're going to have a number of very public comment sessions where we're going to be chunking out 1063 piece by piece and inviting additional feedback and comment. And then what's on the horizon? We're all eagerly anticipating the release of the IBH model and what that looks like, and then continuing to work with our federal partners around opioid overdose. And I know our colleagues from MORE are in the room as well. And then taking a look at the impacts for youth and families on co-occurring IDD and behavioral health diagnosis and adolescent inpatient SUD. Without giving away too much, it's coming, and it's coming very soon. So it's a project that we've been working on. And then CCBHCs, that's certainly also on the horizon. We're also trying to figure out what does that integration potentially look like with IBH. And then 988-911 partnership. Treatment and recovery, ASAM has come out, so we're taking a closer look at that. And then assisted outpatient treatment, I'll talk about that in a second as it pertains to legislation. Talking about technology, and then policy to practice. So we have legislation that was passed around value-based purchasing, and so that pilot, we're actively working with Medicaid now on the application, and then a vast amount of workforce initiatives. I would be remiss, Ryan brought it up as it being one of our utmost priorities, but the BASO transition. So we have contracted with Carillon. It goes live January 1st, but that does not mean that the work hasn't started. So we have been meeting daily with the Carillon team since March, and we are thankful and grateful for their partnership, and we have to get it right? I mean, most importantly, these are people's lives at stake and their ability to access and receive care and treatment. And so we've had a number of stakeholder engagement groups. We're going to continue to have those meetings and that partnership with Carillon. And then what you just see here is a little bit of the roadmap as it pertains to stakeholder engagement and what we're seeking to accomplish between now and go live in January. And lots of testing that's going to go on. We had a really robust legislative session. And so we passed a number of bills. The department, what was it, Ryan? More than 700 bills came through the Maryland Department of Health. And the ones that I just wanted to reference here as it pertains to the Behavioral Health Administration in particular, just a couple of things that I wanted to call out. It really aligns and joins the various different number of work groups and stakeholders. I think there's more than 300 commissions, committees, reports that come out of the department, and we really want to be thoughtful and intentional of how we're aligning this work. It's also an opportunity for us to how we think about governance, infrastructure, building capacity. How do we have sustainable funding, like what we saw through the passage of the 988 Trust Fund? How do we diminish some of the barriers and hurdles that we create for our Marylanders in terms of getting access to licenses, permits, things that they need in order to enroll in insurance and other key benefits. And then a lot of work around partnership and collaborations with our hospitals of how we think about opioid overdose and connectivity to care, building that sustainable pathway for our pregnant and parenting moms and dads so that they can, and I shouldn't only just say moms and dads, those who identify as non-binary or non-gender roles, but have a family that they want to remain committed to and as part of their treatment, remain as part of their treatment. And then making sure we have a pathway for those that have additional language needs to get access to the care that they need. And certainly last but not least is assisted outpatient treatment, which was, I think, a 24-year journey to get us to where we are. And I think you'll hear a little bit more from Erin McMullen this afternoon about the extraordinary work. We are starting that build now, and so have pulled together a number of jurisdictions and partners to help us think about what does AOT for Maryland look like. And with that, I'll shut up. Thank you.
Thank you, Alyssa. That was a lot you have done, a lot you will do. I'm going to ask maybe we only have 2 minutes and 42 seconds, so maybe I'll forego my questions and check with the audience to see if you all have any questions. If not, I have some.
We stunned them into silence.
You have overwhelmed them with all that you were doing. All right, so I'll start with health equity. I saw it was on your goal list, Ryan, for in the horizon. Like, how are we doing today in Maryland with health equity? What are the areas we need to most improve in?
I think one of the things that we are looking to do, and we certainly started with redeterminations, but is really looking at data in every aspect of this and doing a better job, certainly in partnership with the exchange of collecting race and ethnicity data over the course of the past couple of years, and then on the horizon, sexual orientation and gender identity data as well. And then looking at that as part of like all components of the program. The other thing that I think in terms about a health equity and investments of structural systems which aligns with that goal is there's a significant opportunity under our work as Medicaid to partner cross-agency, cross-collaboration within the administration. So we've done more intentional work with the Department of Aging Services, the Department of Housing and Community Development, particularly around our work in terms of the housing space, thinking about some of those structures, Department of Disabilities, Department of Human Services, Department of Juvenile Services. All of those are sort of key components because we recognize that we are sort of one of the key pieces, but we're certainly not the only piece that helps us achieve those goals when we think about system change that government can inform.
Great, thank you. Alyssa, you've been on a tour with these town halls, introducing Carillon and some of the new changes in the BASO. What are you hearing in these meetings? What are consumers most concerned about?
Well, I think resoundingly we've heard, thank you for picking Carillon, in part because of the legacy relationship that we have through Beacon and Value Options and their ability. They've optimized the systems of the prior, but also they're bringing forth the individuals who have partnered with us in the past. And so I think there's a lot of concern about making sure that authorizations, claims get paid come January 1, that we are being transparent about any changes in workflows, and that making sure that there's no disruption in care. That has been some of the key takeaways that we've heard. And then there's a provider survey that's gonna go out in the next couple of weeks where we're gonna get some really critical feedback and then make sure that we are actively addressing it. They just want it to work. They don't want an Optum 2.0. And that is not, and we don't want an Optum 2.0, most certainly.
Well, that, advancing behavioral health here and using Carillon sounds like the right path, and wish you luck with the transition.
Thank you.
Amazing work these two are doing. Let's give them a warm hand and thank them for their commitment to Marylanders and the programs that they represent.